So hello and welcome to episode 8 of the Surgical Discussions podcast with Johnny and Ed. My name is Ed.
And my name's Johnny.
And in this podcast we are going to talk about inflammatory intestinal disorders.
Ooh.
Yeah, pretty exciting, huh? So specifically we're going to talk about appendicitis, diverticulitis, and then finally the surgical approach to inflammatory bowel disease. And particularly, of course, we're going to look at ulcerative colitis and Crohn's disease. So, Johnny, tell us about appendicitis.
I will. Appendicitis is the inflammation of the appendix, the vermiform appendix, which means worm-like.
Because it dangles off like a worm.
Because it's like a worm.
Okay.
Pretty much. Okay, and the severity varies from just edema of the appendix to complicated things such as necrosis and perforation.
Okay.
Peritonitis. So it's very common, probably the most common surgical emergency in the developed world.
Yep.
Affecting up to 12% of people.
Mm-hmm.
And it can occur at any age, but rarely before the age of 2, because before this age, the appendix is very wide where it meets the cecum. It's cone-shaped, so there's not much obstruction.
There's not much room for it to get obstructed.
Yeah.
Yeah.
And so it peaks in childhood years and early adolescence.
Yeah. Okay.
So as we mentioned, there's two main processes. The first is obstruction, and this is normally with a fecalith, which is just feces impacting in the neck of the appendix. Rarely it can be due to worms. And secondly, due to lymphoid hyperplasia. Then it may also become complicated, such as perforation, which locally can cause mass, which we'll talk about in a bit, or generalised, so you've got your general features of peritonitis.
Okay. And lymphoid hyperplasia, what's that due to?
With an infection, the lymph glands around the appendix can increase in size, causing a blockage outside the wall, much like when we describe types of obstruction.
Oh, yeah. I like that analogy. That's good.
Okay, so clinical features. You've got the general features, so your non-specific things, so pyrexia, malaise, anorexia. So you've got the characteristic features of a central abdominal colicky pain, followed by vomiting, and then the pain moves to a localised area of the right iliac fossa around McBurney's point.
McBurney's point, which we're going to talk about in a sec. And the reason this really happens is the appendix is a midgut structure, and visceral midgut structure pain is referred to the umbilicus. So it starts centrally, and then it becomes localized because the surrounding peritoneum gets irritated by perforation, formation of a mass, and localizes therefore to the specific point of the appendix. Constipation is usual, but diarrhea may also occur, so look out for both of these.
So, on the examination, you start with general things. The patient will be still, unlike with kidney stones, when they'll be moving around with the pain.
Writhing around.
Writhing, indeed. They'll have flexed hips and knees, especially if it's a retrocecal appendix. Systemically, they'll have a low-grade pyrexia.
Low-grade, yeah.
And a tachycardia, and then there'll also be a feta oris, which is a smell of vomit from the mouth, and they'll have a coated tongue.
Coated, okay.
Abdominally, they'll have localized guarding and rebound tenderness or percussion tenderness.
Yeah.
And generally, they'll have features such as rigid and all over abdominal tenderness.
Yeah, and that generalized picture represents the presentation of complicated appendicitis with peritonitis. And then the bowel can often become shocked as well, can't it? Causing a ileus with absent bowel sounds.
As we discussed in the podcast before.
Yeah.
So this is where you look for the pain of appendicitis, the localized pain, at McBurney's point, which is found 2/3 of the distance from the umbilicus to the anterior superior iliac spine. Shown nicely here.
There are some very important differential diagnoses to consider, even though, of course, someone of the right age presenting with a characteristic history and the characteristic signs is most likely to have appendicitis. There are important things to consider, particularly in female patients. So gynecologically, for example, in a female patient, a similar pain could be caused by an ectopic. There could be pelvic inflammatory disease, or could be caused by an ovarian cyst rupture or torsion. So always think about these things, and remember always to do a pregnancy test in all female patients. In terms of the gastrointestinal system, apart from appendicitis, there are a number of other conditions that can cause a similar picture. These include mesenteric adenitis, diverticular disease, Meckel's diverticulum, IBD, cecal carcinoma, and a perforated peptic ulcer. Finally, renally, there can be UTI and renal colic. But if you've taken a good history, you should really be able to distinguish between these.
And mesenteric adenitis is one of the common differentials in children, especially.
Yeah, very common in children. So investigations, as always, we follow our tried and tested scheme for investigations. Patented actually, it should be, yeah. So we culture, obviously, urine. MCNS is important because, as we said, one of the important renal causes of this type of pain, or this sort of thing, can be a UTI. You also want to do a dipstick, looking for any blood and things like that, and protein. And then, of course, as we said, all female patients are pregnant until proven otherwise, so you need to do a beta HCG. In terms of the bloods, there are important venous bloods to do. You want to look for signs of inflammation, specifically a neutrophil leukocytosis, which you'd find on an FBC, and a C-reactive protein, which will, of course, be elevated in inflammation. In terms of imaging, ultrasound is useful for two reasons. Specifically in women, it's useful to look for ovarian cysts that may have ruptured or may have torted. And also it's useful to look for signs of appendix inflammation, such as free fluid around the appendix and a diameter greater than 6 millimeters. In cases that are fairly atypical, a CT scan can be used. Finally, and we've put this under investigations, basically because some patients will proceed to laparoscopy for a presentation that is not totally typical and for which they want to look for other causes. And specifically, this is often with women where no cause is found on the ultrasound. Obviously, laparoscopy can then proceed to appendicectomy if necessary. So, management. Of course, another patented thing, we split it up. Well, I don't think that's really ours, is it?
The other thing isn't ours either, but
it should be.
Yeah.
Conservative. Conservative management, often, especially if a patient is presented with an atypical, in an atypical way, you can simply observe them actively, of course, looking for clinical progression. But generally, you want to, under conservative things, do nil by mouth, give analgesia, give fluids, all the normal kind of things. Medically, you should be giving them cefuroxime and metronidazole, particularly pre-surgically. And under surgical options, there are two different types of procedures, an open procedure and a laparoscopic procedure. The laparoscopic procedure is the one that's done most nowadays and is particularly good for girls because, as we said, you can have a good look around in the abdomen to look for any other causes. So under the open operations, there are two very important scars that you should be recognizing on your abdominal inspection. These are the Lance scar, which is more horizontal, as shown on the diagram, and the McBurney or gridiron scar that is more oblique. And obviously, if they've had laparoscopic surgery, there may be signs of laparoscopic incisions and port insertion points as well. So the complications, there are three important complications to be aware of. Perforation leading to a generalized peritonitis is most common in the very young and the very old, and it may lead to reduced fertility in females. The formation of an appendix mass may need appendicectomy, but can be treated conservatively and medically with antibiotics.
And that happens when you get omentum covering the appendix.
Yeah.
Is that correct?
Yeah, that's correct. And then finally, in an appendix abscess, you can give antibiotics and you can drain this as well. So we're going to move on now to talk about diverticular disease.
Right, a couple of definitions to start with. So
yeah, I often get confused actually about these definitions. So yeah, let's go through them.
Okay, so diverticular disease is an acquired condition with mucosal lined outpouchings through the wall of the colon.
Okay.
So a diverticulum is a single outpouching.
Yep.
Diverticulosis is when many of these are present.
Yep.
And diverticular disease is when these become symptomatic.
Okay.
That's important.
Another important point is that diverticulosis represents the presence of multiple false diverticula. These diverticula are false as opposed to true because they don't represent a complete outpouching. It's just mucosa lined. In Meckel's diverticulum, for example, which is a congenital condition affecting the terminal ileum due to embryonic development, you get a true diverticula, which is basically an outpouching with all of the layers of the bowel wall present within the pouch. So diverticulosis is the presence of multiple false diverticula.
It's interesting.
Aside, but add some juice to the podcast. That's what I like.
Okay, epidemiology.
I'll shut up now.
Well, you can continue if you will.
No, go.
So it's common, found in 30% of those over 60, but as we've mentioned, it's often asymptomatic. It's more commonly found in women, and the risk factors can be split into those of the lifestyle, so obesity and a low-fibre diet, causing
particularly important. Yep.
Causing constipation,
increased intraluminal pressures, causing the bowel wall to herniate at the site of the arteries entering into the wall. Yeah.
And other conditions, so hiatus hernia, which we've mentioned beforehand, and cholelithiasis. And if these are combined, it's called the Saints Triad.
A wonderful eponymous triad to remember again.
Over to you.
Over to me, okay. Clinical features. Well, most diverticulosis, most patients with diverticulosis, you see, I'm already getting jangled up in the jargon. Most are totally asymptomatic, but symptomatic patients, i.e. patients with diverticular disease, will have one of two presentations, or two sets. One group of patients will simply have a mild alteration in bowel habit with some left-sided or without some left-sided colic. The other group of patients will have one or more of the complications that are attributable to diverticular disease. And these complications are here on this slide and can be remembered using the mnemonic, do hairy people always feel sad?
Maybe you could have a little competition where you give something away for a better mnemonic.
Yes, we did think of some better ones, but they were a little bit too rude to put on.
Risque.
Yeah, this is a podcast for many different ages.
Okay,
so we can't put anything.
So anyway, back to the matter in hand.
So, do hairy people always feel sad? Diverticulitis, which presents with a kind of left-sided appendicitis. That's the way I like to think about it anyway. Hemorrhage is very common. Often it's a sudden hemorrhage, painless, and it causes a very large PR bleed. Perforation can occur, leading to a peritonitis. Abscesses can form, leading to swinging fevers and boggy rectal masses. There can also be a fistulae, either into the vagina or into the bladder. If it's into the vagina, it's called a colovaginal fistula. And if it's into the bladder, it's called a colovesical fistula. And the characteristic sign of colovaginal fistula is pneumatochuria, which is air bubbles in the urine. And finally, there can be the formation of strictures due to inflammation, fibrosis, etc. And this can lead to a large bowel obstruction. The investigations that you perform obviously will depend upon the way that your complicated diverticular disease patient presents. You might want to do a cross-match for
a hemorrhage.
Yep, a hemorrhage. Yep. And an erect chest X-ray, for example, looking for free air in a perforation. For diverticulitis, however, which is probably the most common complicated disease presentation, You, of course, want to look for signs of inflammation, such as a leukocytosis, raised CRP. You want to do various imaging tests. An abdofilm can be done. This is not very good at detecting diverticulitis, but there can be a fluid level and air within the wall of the bowel. Barium enema can also be of help, but remember, only use gastrographin because barium is quite toxic and less water soluble. So if there's a perforation, it will cause a very nasty peritonitis.
So where it says barium enema, you meant gastrographin enema, probably?
Probably, yeah. Okay, I'm an idiot. CT scan is also important, and in fact is the gold standard test in diverticulitis. And ultrasound is used rarely. Scopic investigations, you can do sigmoidoscopy and colonoscopy to visualize these outpouchings directly and to look for associated complications. So here we are, two images here. One is a double contrast enema showing the presence of multiple diverticular, particularly in the sigmoid colon, but I think I can see some in the ascending, no, not the ascending, the descending colon as well.
Seems to be forming a little stricture around that area, possibly with a few features of obstruction.
Yeah, actually, there's some obstruction there. Okay. And then on the right, the colonoscopy, and I think you might be able to persuade yourselves that those are little holes in the bowel wall representing these outpouchings. So go for it, management.
Okay, in mild disease, we start with the conservative once again. So modifying lifestyle risk factors. Yeah, so lose weight, increase your fibre and fluids to decrease constipation.
Yep.
You can have antispasmodics, so things such as mebeverin.
Very good drug.
Medical. And with acute diverticulitis, if it's mild, then you can go home and just have fluids orally and use coamoxiclav.
Yep, and it should settle down.
Yeah. Whereas if it's a bit more severe, then once again, nil by mouth fluids and adequate analgesia, and then medical treatment with cefuroxime, 1.5 grams over 8 hours, and metronidazole 500 micrograms. Milligrams, sorry.
It's all right. All here to learn.
Okay. And surgical management, this is indicated in complications, so in perforation, hemorrhage, and obstruction. So in emergency cases, you'd do a Hartmann's procedure, which we'll talk a little more about later in another podcast. But
in fact, we've already spoken about it.
Have we?
Yep.
Okay. And also elective, so sigmoid colectomy and then anastomosis to the rectum stump.
Yeah, because you want to avoid having a colostomy if possible. So we're now going to talk, hopefully quite briefly, about inflammatory bowel disease. Most of this stuff is covered under medicine, and although there's no podcast on the website, you should go and read up about this from a medical point of view. So specifically, we're going to talk about ulcerative colitis and Crohn's disease. So I'm going to talk about ulcerative colitis, and Johnny's going to talk about Crohn's. UC can be defined as an inflammatory condition of unknown etiology that affects the large bowel. Importantly, it always starts at the rectum and then extends proximally. Approximately 20% of patients will have a pancolitis. It's a very basic epidemiology. It's more common in women, particularly middle-aged women between the ages of 20 and 35, and it's more common in non-smokers. It may be totally asymptomatic, or it may be symptomatic, in which case presentation can be acute, intermittent, or chronic. The clinical features can be divided into general, specific, and extra-intestinal. So an important general feature would be weight loss due to associated inflammation and a level of malabsorption. Specific features can be diarrhea, which may contain blood or mucus, crampy abdominal pain, and rectal symptoms, particularly tenesmus and urgency. Ulcerative colitis is one of these inflammatory bowel diseases that causes a number of extra-intestinal manifestations, and some of the important ones to remember are uveitis, ankylosing spondylitis, and erythema nodosum. In terms of the examination, in mild disease, the patient may simply be clubbed with no other obvious signs, but they may, for example, have a ileostomy or colostomy in place. In acute disease, they may be tachycardic, they may have a pyrexia, and specifically they may have a particularly tender abdomen and have had acute PR bleeds. It's important to be aware that often in this age group of people presenting in the way that they do, you'll often think first of gastroenteritis. And obviously you don't want to be sending these people home if they have an acute presentation of ulcerative colitis, as things can go quite badly. So always think about UC in a young woman or man presenting with gastroenteritis. Just have it at the back of your mind. So some of the complications, important complications of this condition are toxic megacolon, perforation leading to a peritonitis, the formation of strictures which may result in large bowel obstruction, and finally perianal disease, which we're going to discuss in more detail in our next podcast. Investigations, as always, we go through the same protocol. I've already mentioned that gastroenteritis is an important differential diagnosis, or I should perhaps say UC is a more important differential diagnosis for gastroenteritis, but you should be doing a stool culture to exclude infection. If they're septic, you may want to also do a blood culture. In terms of the bloods, a number of different ones are important. Standard FBCs, U's and E's. If these patients have had particularly severe diarrhea, for example, they may be slightly hypokalemic. You want to do a CRP, looking for infection. Albumin, they may have chronic albumin loss, leading to malnutrition. And if they're for surgery, you want to, of course, do clotting, group and save, and perhaps think about a cross-match. In terms of imaging, an erect chest radiograph may show signs of perforation, such as free air under the diaphragm. The abdominal X-ray may also show signs of complications that can be attributed to ulcerative colitis, such as toxic megacolon and the formation of strictures and associated obstruction. You can do an enema, either of barium or gastrographin, and this will show a typical triad of lead piping, loss of haustra, and granular mucosa. Finally, CT is also an option. Moving on to scopic investigations, you can do sigmoidoscopy and colonoscopy and biopsy, which will show limited or no serosal involvement and crypt abscesses. So, management. We're not going to talk about chronic and intermittent forms of ulcerative colitis because management of these is predominantly medical. However, in the severe attack, the surgeons tend to get involved. And what is a severe attack? It's an attack that can be put into the True Love and Witts criteria and tends to be based around the number of bowel movements, the presence of blood, and the presence of systemic upset caused by the episode. Management, of course, can be conservative. So your patient may be nil by mouth. They'll need to have fluids and analgesia. There can be medical management. So you want to try and dampen down this inflammation in the bowel, and this can be done in two ways. You want to give them IV hydrocortisone and also rectal steroids. And this is in the form of prednisolone foam enemas. Obviously, if they've been bleeding heavily in association with their colitis, they may need a blood transfusion. So, if your patient improves and there aren't any complications, then they should be started on prednisolone and sulfasalazine. If they develop complications or are refractory to your medical endeavours, then they may need a total or subtotal colectomy with an ileostomy. Some patients who have chronic symptoms or high grades of dysplasia or carcinoma, that's something actually we didn't mention earlier. Ulcerative colitis puts you at an increased risk of developing colorectal carcinoma. Then some of these patients are suitable for elective surgery, which can be done in a number of different ways. You can do different levels or remove different levels of colon, and this goes from a pan-procto colectomy to subtotal colectomy. And then you can either do an ileostomy, anastomosis, or form an ileal pouch.
over to me.
Over to you. So I've gone on quite a long now.
No, that's fine. That's fine.
It's a difficult topic.
Crohn's disease is very like UC. It's once again an inflammatory condition of unknown etiology, but this affects the entire length of the GI tract, unlike UC. Commonly, it's found peak incidence is at 20 to 40 years, and it's found in smokers, unlike UC, and it's equally distributed between males and females. Characteristically, you get a patchy transmural inflammation with non-caseating granulomas throughout the length of the GI tract.
Mm-hmm.
So, clinical features. These depend on the site. As we said, it can affect anywhere. It can affect the esophagus all the way down to the rectum and the colon. So it depends on the site. Generally, you can have weight loss and a low-grade pyrexia in acute attack.
Mm-hmm.
Specifically, you can have anything. This can range from diarrhea, maybe bloody, abdominal pain, and features of obstruction. You can also get things in the mouth, such as aphthous ulcers, and things like that.
Okay.
Extraintestinally, you get similar features to those of UC, so ankylosing spondylitis and erythema nodosum.
Yeah.
So, generally, on examination, you can once again have clubbing and the aphthous ulcers, which mean ulcer-like ulcers.
Good. A breaking it down. I like that. Yeah. Latin scholar, you are.
I am. Abdominally is tender, and you might have a right iliac fossa mass.
Yeah, that's a very important, actually, Crohn's disease is a very important differential for a right iliac fossa mass, isn't it?
Mm-hmm.
Yep.
And you may have perianal disease, which we'll talk about later, but things such as skin tags, fistulas, and fissures.
Nasty stuff.
The investigations are very similar to that of UC, so once again you'd do your stool culture and your blood cultures, the same venous bloods. With the imaging, you'd once again do your radiographs, chest radiograph for complications such as perforation, and abdominal radiograph for toxic megacolon. And then you'd do a gastrographin or barium enema, and there's also you can use a barium follow-through or gastrographin follow-through, as it may affect the whole GI tract and not only the lower part.
So that's good because you get particular information on the small intestine.
Yeah. And you can also do a CT.
Yeah.
Scopic investigations are those of colonoscopy, which have characteristic features of a cobblestoned appearance, fissuring, and serosal involvement. So this marks it out as different from UC.
Yeah.
So here we can see the barium follow-through, showing all the features that we've just mentioned. So strictures, the cobblestoning, and the fissuring.
Yeah.
The GI tract. Management. Obviously, you can use conservative treatments, as we've mentioned, so analgesia and things like that.
Yep. Nil by mouth fluids.
Yep. Yeah. Medical management is similar, so steroids and immunosuppressants.
Yeah, we're not going to get bogged down here with that because
That's
it's incredibly complicated. Yeah.
And then you can do surgery. So in emergency, you're treating the complications, whereas elective, you're treating the chronic problems that occur with Crohn's disease.
Yeah, so quite similar to UC.
Very similar, yeah. So your options are, once again, you can do limited resections of the bowel, ileocecal resection, and removal strictures with stricturoplasty.
Yeah. So that's about it. In summary, we've looked at appendicitis, its presentation and treatment. We've looked at diverticular disease, particularly the different types with mild, acute, complicated diverticular disease. And we've looked at some of the important medical and surgical options that are used to treat this condition. We've then had a quite extended look at IBD, particularly the surgical aspects, considering UC and Crohn's, the differences between them in terms of where they affect, the different radiographs, that the different features that may be affected on the radiograph. And that's about it. So thanks for listening. Eat lots of fibre, and we hope to see you soon. So goodbye from Ed.
Goodbye from Johnny.
Bye-bye.
So Crohn's disease is very like ulcerative colitis. Crohn's disease is very like ulcerative. Crohn's disease is very like ulcerative.
Fucking up my timings.
Sorry.